So we will now move to the final session, going back to our trainee presentations, and this session will be chaired by Dr. Catherine Howe.
All right. The timeliness factor. I've got Dr. Failings nudging me along. So for those of you that want to stretch your legs, please stand, but we're going to get started with this afternoon's session. I hope you found today as inspiring and as informative as I have. And please, I hope you're still excited, despite the late hour in the afternoon, for our last but very key session. We're going to start with Edgar. And we'll just get you to, great. Can AV put up the slides, if you don't mind? Edgar's an incoming dermatology resident at the University of Toronto with a keen interest in advancing health equity. Before pursuing medical school at the University of Toronto, he completed his undergraduate and graduate studies at Cornell. And please welcome him up to talk to us today. Thank you.
Thank you.
Thanks, Edgar.
All right. Hi, hello everyone. My presentation today is barriers to Black medical students and residents pursuing and completing surgical residency in Canada. This was a 2-year project that was supervised by Dr. Jory Simpson from St. Michael's Hospital and co-led by other medical students as well. So a bit of background as to why we did this project. The limited available data we have in Canada suggests that the Canadian surgical workforce does not reflect the racial diversity of the patient population it seeks to serve. And it's also really well established that there are benefits for having a patient-provider race concordance, even in surgery. One example is Black patients are more receptive to a surgeon's recommendation for surgery when their surgeon is of the same race. And I think that was a notepad by one of the residents from U of T kind of indicating that. Patients also rated their visits with a physician as more satisfying when they were of a similar race. Other studies, from the U.S. have found that students from marginalized groups, including Black students, are less likely to pursue surgical careers, and this kind of affect the diversity that we reported on. When we looked at the literature, most of the prior Canadian studies had kind of focused exclusively on residents. There were no studies that did really seek to kind of learn from the medical student experience as to why they were underrepresented in surgery disciplines. So we thought as the number of Black medical students in Canada increases, it's really important for us to understand the unique barriers they face when they try to assess surgical specialties. And this is what led to this study. So our main objective for this project was to really explore the experiences of Black medical students when they apply for surgical residency within Canada. We had some sub-aims as well. One of them was to explore, the progression of the percentage of Black participants. Yeah. Okay, sorry. So in terms of, how this study came about, it was a qualitative study. So we employed purposeful sampling to make sure we were including both medical students and surgical residents to also learn about their experience when they applied. It was a Canada-wide study, so participants were included if they were currently enrolled in an undergraduate program or a postgraduate program within Canada, all the 17 Canadian medical schools we sought to recruit from. Another key inclusion criteria was to be Black as well. Recruitment took place between March 2022 and September of 2022. After we recruited our participants, we had a 45 to 60-minute semi-structured interviews, which was conducted over Zoom because it was during the pandemic, to really explore their interest in medicine and their experiences if they've done surgical rotations as well. So a little bit about the demographics of the people that participated in our study. We had 27 participants, of which 16 identified as females and 11 were males. We also tried to kind of get a sense of their socioeconomic statuses growing up. And as you can see, we had 7 of them who were residents at the time of the interviews. Most of them did identify as having like a middle socioeconomic status growing up. And when it came to the medical student, we had 20 medical students, and similarly, a majority of them had a middle income growing up. We tried to recruit across the whole country, but of course, most of our participants came from Ontario and Quebec. And then we had a good representation also from the prairies as well. And then 7% came from the Atlantic and the West Coast. So in terms of once the interviews were done, we had the support of a qualitative researcher from St. Michael's Hospital to really help us with our analysis. And these themes became evident. One of the core themes that we explored was our journey to and through medicine. So really learning about the participants, what motivated them to apply to medicine, and kind of learn about their journey and some of the barriers that they found. And I'll go through most of these themes and their sub-themes in the next few slides. So the first theme that was very apparent was the journey to and through medicine, and under this sub-theme there was the motivation to pursue medicine. And so we really tried to understand why these participants had enrolled in our medical school. And this is a quote from one of the participants who said, "A huge part of me really wants to do general surgery, but I've been very hesitant to go fully into this idea because maybe I will not be able to do the same type of advocacy that I would have been able to do in OB-GYN." And that was a recurring theme for some of the participants where they felt there wasn't room to advocate in surgery compared to OB-GYN. But I wish they were in the room today to know, hey, there are also ways to advocate within surgery. And this kind of speaks to some of the next points that I will get to. And the main takeaway from this was that Black medical students were more likely to consider primary care and public health specialties due to this, what I call a self-imposed moral obligation to pursue primary care practice to fill some of the care gaps that we have learned about today. And they perceive some of the surgical specialties to be lacking community impact. And I've learned today personally that this is not true. The other sub-theme under the journey was kind of learning more about when they had applied either to residency or to medical school, their experience with admissions. And one of the participants did share that it feels kind of unfortunate that maybe there isn't as much weight that is put on advocacy initiatives and efforts because I think a lot of Black medical students end up focusing a lot of their efforts over there. So there was this recurring theme that currently how admissions have been structured, there is a big emphasis on research and advocacy sometimes does not merit the same type of points when it comes to admission considerations. And the main takeaway over here was that Black medical students were more likely to have engaged in advocacy and other community building initiatives that are perceived not to be formally credited in the surgical residency admission process. So when it came time to applying and they look at on their CV and their resumes, they realize, oh, I'm not a good candidate because I don't have research. But then if they knew that advocacy could equally count as research, then they may have been inspired to apply. The other sub-theme that we did explore was that of our social capital. As most of these students were coming from low to middle socioeconomic statuses, it was important to kind of see what role that played in their journey here. And one of them shared, I had no Black mentors, but regardless, I got here. I appreciate a mentor who is honest, shares candid experiences, and maintains confidentiality. And I think that one of the more important things, genuinely cares and wants to help. We also try to kind of learn from the participants if there was any need for mentorship to come from somebody who was of the same race or, let's say, cultural background. And overwhelmingly, most people said it didn't matter. For them, they cared about someone who could listen, someone who could share insight and really provide that candid mentorship. And the key takeaway over here was that most participants were their first in their family to do medicine. So they did not know how to pursue research, how to find these opportunities, and having a mentor would have helped them along the way. And then now moving on to the other big theme, which is the sense of belonging. and under that came isolation. Most of this kind of applies to people who've been able to make it into surgical training programs. And one of them did share that as a Black surgical resident, you are one of either a few or the only. The lack of belonging and the isolation that comes with it can impact your psychological well-being. It has a huge impact on the depression and anxiety that you feel as a Black resident. So for them, having, solidarity in numbers would have been helpful as they trained. And the key takeaway was that most Black medical students struggle with the idea of being the only Black surgical resident in their institutions and the possible impact that could have on their well-being. So they were deterred to apply to programs where there are Black residents already in the program. And then on that theme of sense of belonging, we also took a look at microaggressions and verbal abuse, if it had occurred, for people who had gone through clerkship or those who were in surgical residencies. And this was one participant's experience talking about over-policing. If I would do something that was neutral, according to the participant, something either good or bad, people you wouldn't even expect, like nurses or physiotherapists, were reported to the program director that I did something wrong. People will lie to my program director about things like that. So I was constantly defending myself, and I was baffled why they were doing this to me. So they really felt isolated, alone, and felt that there wasn't anybody to really help them. And while this wasn't an overwhelming theme, it was something really important for us to share. And the key takeaway over here was some Black medical students that share that during their surgery rotations, they receive a bit of unsupportive remarks from their supervising staff and were left wondering if they were receiving these comments because of their race. Residents also shared that compared to their non-Black colleagues, they were overly supervised and criticized about their surgical skills. They were sometimes even encouraged to switch from surgery to another specialty if they were unhappy with the treatment they were currently receiving. And I think that type of feedback may not be helpful for a learner who's really new to this. And I think also in the sense of belonging, gender, the intersectionality between being Black and also being female also came up. And one of the participants did share, if all you see are male preceptors, it subconsciously direct you in a certain way. I did orthopedics as an elective, and they were all males except for 2 surgeons. I once considered urology, but when I thought about it, how many female urologists are there? So I think representation really did matter for some of these students, and seeing themselves represented at the table was of importance to them. And the main takeaway over here was that the intersection of race and gendered experiences also influenced the specialty choice of Black female medical students. And it kind of explains why we see this trend of most of them going into OB-GYN and other surgical specialty, but not general surgery. Once we had, all of this, the other theme was about the surgical culture, trying to really kind of get a taste from the students what their experience had been when it came to lifestyle and culture. And I think this applies not just for Black medical students, but I think all students across Canada and even residents. Most of them did talk about suboptimal work environments, working long hours, sometimes having to deal with challenging personalities and hierarchies within surgery was also things that people did share. On the other hand, there was a bit of sleep deprivation due to what they called lax duty hours enforcement. So I think they are supposed to work up to 26 hours, but that was not always respected. And the call schedule could sometimes also be inflexible. Some people did share that as well. But I think for me, the more important thing was that the participant did endorse a shift in culture that promoted collegiality and a supportive work environment. So across the board, most people we talked to were like, oh, while there's this thing that happened, overall, it was a really, really great experience having my surgical elective at XYZ Hospital because the staff were really nice. They all found positives despite some of the negativities that they did share. So, while the field of surgery was deemed as mentally and emotionally, physically demanding, there is a bit of that change and people still wanting to still do it. So I guess in terms of once we had all of this at our fingertips, it was really important for us to kind of know what are we going to do next. So instead of us crafting recommendations, we did ask the participants, what would you like to see in your program? If you were a resident and if you were a medical student, what would you like to see? So I will share the residents first because I think first and foremost was about the working environment. And most of them recommended, having a program that promotes collegiality and a supportive work environment, ensuring that, it also counters racism and fosters inclusivity. So this applies for, I think, most people. They also recommended having mandatory training programs for the staff that they'll be working with on things like implicit bias and anti-racism, just so all learners will feel equally valued and understood when they are in these surgical spaces. They also, some of them, they speak about having transparent processes, because some of them were not sure how to even go about things like maternity leave, if they were thinking about that in the future and stuff like that. And then the other piece was, I guess, to do with the admissions file review process. They were hoping programs could demonstrate their commitment to promoting diversity, equity, and inclusion by establishing pathway programs. And this has been done by internal medicine and some few other specialties, so it can be done. And I think for participants, this signaled that the programs were willing to change and were willing to really support them if they were to train with them. Another piece was with the admission process to allow applicants to substitute advocacy initiatives to fulfill research requirements. And that will encourage them to apply for people who may be lacking research but have done advocacy work. And then also, last but not least, consider mandatory implicit bias training for all interviewers and file reviewers. And I think this is happening for some of the programs already. When it came to students, mentorship was really key. Most of these participants were first in their family to pursue medicine. They did not know how to navigate this journey. So having someone to kind of guide them through the process was really, really important for them. And already that we've seen some progress in this domain with the Black Physicians of Canada starting a mentorship program. So for individuals in the room who would like to sign up to, I would encourage you to do so, to serve as our mentors. And one thing that also came up was to establish a national surgery interest group to enable students from other regions in Canada with limited access to Black surgeons to network. So there are some people, mostly from Atlantic Canada, who may not really kind of come in contact with surgeons who look like them. So having a national surgery interest group would be beneficial for these individuals who would like to network. And then last but not the least, to consider a holistic review of applicants' files and recognize the complexity of lived experiences that applicants bring to the table when they apply to even medicine and surgery. I think the article has been published in the Journal of the American College of Surgeons, so I encourage anyone who would like to delve deep to read about it. It's a bit too much to kind of distill in 10 minutes, and I hope you enjoyed the presentation and open for questions.
Thank you. A quick question, yeah, thanks.
Yes, hi, I'm Kristen Dowdge. I'm a plastic surgeon at SickKids. I really enjoyed your talk, and I think you brought up really important issues, and I'm so glad that you're here to present it, even though it sounds like you're not going into surgery at the end of the day. And it continues the theme of equity, not only in access to healthcare, but also in access to training. So my first question for you is more of a methodology question. And I'm just curious, what is the data or literature out there on when you're conducting a qualitative study in a racial minority or around culturally or racially sensitive issues? How does the gender, race, or culture of the interviewer influence that transcript and that willingness to disclose in an interview? And did you think about that in the planning of your study, and what do you know about that?
No, yeah, that's a great question. I think that speaks to, before we began the whole process, we had a bit of that reflexive statement that we all wrote. So all of the co-investigators kind of wrote where they were coming from, the lens that they brought to this research, and that was really, really useful to kind of have that established right from the onset. I think what really also helped was that all of the interviewers and people in the research team were Black students as well. So when it got time to kind of really now have that chat with our colleagues, initially with the first, let's say, 5 minutes of the interview, there's a bit of that wall that is there. People are not safe to kind of share with a stranger they've just met over Zoom. But then once, they realize you also of the same race, we're going through medical school with them, it kind of lightened up a little bit as, the interview progressed, and it allowed us to kind of uncover things that I personally believe they wouldn't have shared if not having another like black person interview them. So we're able to really uncover some of the nitty-gritty things that usually don't come up in our paper, and to us, I think that was positive. And I'll actually encourage individuals who do this type of work to kind of at least include people from that demographic on the research team to kind of bridge that divide. Yeah.
That was a good answer. And then the other question I had is that there was a number of things that were brought forth by your interviewees about what we could change for the future. So based on your knowledge of the literature and kind of your work on this project, what do you think are the most important or actionable items that we can do to enhance representation in our surgical residents?
No, that's a great question. I think the team is currently kind of thinking about next steps. We've had this kind of series of recommendations. How do you implement them? And I would say Dr. Simpson has been very generous with his resources for us to kind of put some of these into practice. So we'll be starting like a working group to kind of begin with usually third and second year medical students to really kind of put some of these ideas into practice. I think that next piece about, how do you kind of go about, I think the biggest thing that was screaming at us was mentorship. Several applicants were like, oh, I would have loved to apply to surgery, and they kind of figured this out around like fourth year. And they are coming in with no research on their resumes, and it's really hard. It's a competitive specialty, so it's like really hard at that time if you've made that determination to be able to adequately compete. So what we are now hoping to do is like have mentors at the table, either through the Black Physician Association of Canada or even within our own mentorship program, to ensure that these participants and these students, if they want to explore surgery, at least have researched at their doorsteps and stuff like that to do. Mm-hmm.
Thank you very much.
Thank you.
Thank you very much. I'm going to call Hoyi up to the podium, please. We're going to talk about female mice display sex-specific differences in cerebrovascular function and subarachnoid hemorrhage-induced injury. Thank you. Welcome.
Thank you. This is the clicker? Yeah. Hey there, my name's Hoyi. Thank you for that introduction. I'll be talking a bit about some work that I did during my postdoctoral fellowship, extending a bit into the first several years of my residency, where I investigated how female mice display sex-specific differences in cerebrovascular function and subarachnoid-induced injury. And this study was done underneath the auspices of Dr. Stefan Baltz, who's a professor here at the Department of Physiology. And so our lab really focuses on looking at myogenic response. And so just a brief review or overview of what myogenic response is the intrinsic ability of a resistance arteriole or artery to constrict in response to increases in pressure. And this is modulated through the activation, simplistically, through the activation of stretch-activated calcium channels, such that when there's increased pressure, there's increased stretch on these calcium channels, and it causes an influx of calcium into smooth muscles and causes constriction of these arteries. And this allows us to maintain on a steady state of flow in our tissues through a mechanism called autoregulation. And so through a large number of driving pressures, and we can maintain a constant flow. And so how we study myogenic response in our lab is utilizing something called pressure myography. And so what we do is we cannulate small resistance arterioles. For this specific project, we cannulated olfactory arteries, which are a branch of the anterior cerebral artery. And these are very small vessels, about 30 microns in size. We place them onto small glass pipettes. We place sutures on them, and we pressurize them to different pressures. And you can see on the graph in the middle there, you can see that with increased pressure, you can increase myogenic tone. And this is expressed as a percentage of the maximal tone, which is characterized by putting a high dose phenylephrine for the maximal tone. And you can see in the disease state, for example, in subarachnoid hemorrhage, you can see that there's increased tone in mice. And in comparison, when we look at our control group in phenylephrine, there's no difference between the two groups. And so early on in this project, we identified that cerebral myogenic response has a circadian rhythm. So these mice are housed in 12 to 12 light-dark cycles, and so it's 12 hours with the lights completely on, and then the last half hour or so, the lights become dim, and then you transition into a dark phase. And if you recall, mice are nocturnal creatures, so they're most active in the night. And so what we see in our study, and this first study that was at the night, we see that there's higher tone at night, with the maximum at Zeitgeber time 23, which is just the hour right before the lights turn on. And during the day, there's the lowest tone, which is minimum at ZT11, or Zeitgeber time 11, which is an hour before the lights turn off. And so we were interested in seeing whether this difference in this myogenic response at different time points is actually functionally relevant. Probably at baseline, it probably doesn't matter all that much, because there's other mechanisms that can, there's other mechanisms of autoregulation that are also important that can probably override this change in tone. So we were interested in the disease state, and my PhD really focused on subarachnoid hemorrhage, so this was kind of a perfect infold into this project. Subarachnoid hemorrhage, as most of you who've done a trauma rotation know, is most commonly caused by trauma. However, spontaneous subarachnoid hemorrhage is most commonly caused by an aneurysmal rupture, and that's bleeding into the subarachnoid space where the CSF is. And it's associated with significant morbidity and mortality. Over the last 40 years, there's really been no significant improvement in the mortality. Still approximately about 40% of people who have an aneurysmal subarachnoid hemorrhage will die, and about another half of those who survive will have significant morbidity from a variety of causes. And so in this first study, we looked at the myogenic tone, as I mentioned before, and then we induced subarachnoid hemorrhage using a prechiasmatic injection model where we injected blood into the prechiasmatic cisterns of mice, either at the ZT11 time point, so during the day, or under red light conditions at a ZT23. And we looked at the behavior of mice at the 2-day time point after we induced a stroke, and then we looked at the histological endpoints as well, looking at fluorogate and caspase-3, which are both markers of cellular apoptosis. And so what we find is that these oscillations in cerebral myogenic tone really influence subarachnoid hemorrhage-induced injury. We can see, again, in the lower left-hand side, that there's a difference between the ZT23 and ZT11 time point, especially at the 80 millimeters mercury pressure, which is what mice physiologically live at. And then we can see that at the ZT23 time point that there's more injury. So in summary, what we see is that at the night, where there's higher tone, there's more injury. During the day, there's lower tone and there's less injury. And this also correlates through our behavioral results as well, where we looked at the modified Garcia score, which is a gross measure of cognitive function in mice, where we look at various parameters, how well they move, and as well as their sensory abilities. So this is essentially a summary of what we found in our first study, which was published back in 2022, where we found that essentially higher tone at night equals worse injury, and higher tone during the day, less tone during the day leads to less injury. However, one of our reviewers astutely pointed out, probably reviewer 2, that our study only included male mice. So the question that they had was, what about female mice? And probably in our response, we'd probably written something facetious like, including female mice in the study increases the variability of our studies, so we did not include female mice in our study. But that kind of got us thinking, well, what if there is a difference in the circadian rhythm in female mice? So we replicated the study, and this time in female mice. So essentially the exact same setup with the myogenic tone, subarachnoid hemorrhage induction, looked at the behavior, and then we assessed the histology. And so what we find very interestingly is that female mice do not have a circadian rhythm in myogenic tone. In fact, it's almost completely dampened to the point where there is no variation between ZT11 and ZT23. And you can see in the lower right-hand corner that in the male mice, we still have this response in this study as well. So what we then looked at was whether the time of subarachnoid hemorrhage induction, whether that affected the brain injury in female mice. And indeed, it does not. There is no, it doesn't matter what time we induce a subarachnoid hemorrhage, it does not, in fact, affect the brain injury, which is completely different phenotype than in our male mice. So we then thought, okay, well, what could be causing this fluctuation in terms of the loss of the circadian rhythm? So we figured, oh, is it due to estrogen? So we decided to repeat the same experiments on overrectomized mice to see if estrogen or circulating estrogens were an important putative factor here. And overrectomy does not, in fact, unmask circadian variations in myogenic tone. And similar to our previous results in just the wild-type female mice, there was no variation in the subarachnoid hemorrhage-induced injury. And so, in conclusion, female mice possess a very distinct cerebrovascular phenotype compared to males. There is no diurnal difference in subarachnoid hemorrhage injury in females, and overrectomy does not restore the male phenotype. And these results are probably fairly esoteric and probably not all that interesting to people in this room. I think what's more important is that the study emphasizes how important it is to include female subjects, especially in our biomedical studies. I think during my PhD, I probably read over 1,000 papers. Just based on my experience in the field of subarachnoid hemorrhage, very few papers included female mice in their studies. And for me personally, probably published about 5 or 6 studies. I probably included female mice only in 1 study. And there's a very interesting article that was recently published in Nature, showing that we're talking about how male-female comparisons are still powerful in biomedical research and not to abandon them. And there's some people that say that binary sex studies may be too simplistic, but I think that based on the results that we've shown here, that there are some differences between males and females that may be of some interest, and we should probably pursue them. In fact, down here it says only 26% of biomedical studies in animals included female mice in a systematic review. And so I just like to acknowledge our funding agencies, and if anyone's interested in looking at the study, there's a link down at the bottom.
Thank you very much.
Hi, Dr. Wan. James from University Health Network. Really great study. I just had a couple of questions. The interesting part about the study is obviously the lack of the circadian rhythm in the myogenic tone. Have you ever considered using circadian disrupted lines, like clock gene disrupted lines, BML disrupted lines, in either a conditional knockout of vascular tissue?
Yes.
To see whether or not male mice with a circadian disrupted tone would have a similar behavior to the female mice in these experiments?
Yeah, so in the first study we did use BML knockout mice, specifically in the smooth muscle population, and we found that you can eliminate the circadian rhythm. And in fact, the circadian isn't quite eliminated, it's actually reversed a little bit, where there's an isolated peak at ZT11. And so in that study, we demonstrated that at that isolated peak that there's more injury at that time point. So essentially the phenotype is actually reversed. So they show a very distinct phenotype in our knockout mice as opposed to the wild type line.
We did some studies in our lab in a model of ischemia reperfusion injury, and we primarily work with female animals, and we saw there was tons of RNA level changes in non-coding RNAs that were maternally associated. Looking into the literature, there's a lot of literature looking at how females may be predisposed to certain ischemia reperfusion after ischemic stroke. Did you guys look into any RNA level changes in these kind of genes that are X-linked?
Not specifically X-linked. The only RNA sequencing that we really did in this project was looking at CFTR regulation because it's inherently related to our myogenic tone, and there's oscillation of CFTR in both male and female mice, and this seems to drive to some extent in male mice the variation that we see, but nothing specifically X-linked that we looked at.
Thank you very much.
Thank you.
I'm going to call Ben Lee up to the podium, please. Ben is one of our vascular surgery residents who's going to talk to us today about using machine learning to predict outcomes following carotid endarterectomy. Welcome.
Thanks, Dr. Howe. Well, I'm really excited to share with you our work on using machine learning to predict outcomes following carotid endarterectomy. Carotid artery stenosis involves plaque buildup in the carotid artery, and it's responsible for 1/3 of ischemic strokes, which, as you know, is a leading cause of mortality and morbidity worldwide. Carotid endarterectomy, or CEA, involves surgical removal of the plaque, where we make an incision in the neck, get down to the carotid artery, and endarterectomize the plaque. However, there are major neurovascular structures in this area, and therefore, This procedure carries significant risks, including a perioperative stroke or death rate up to 10%. Therefore, accurate prediction of outcomes following CEA is critical for guiding clinical decision-making, such as deciding which patients to operate on. Currently, there are no standardized tools to predict outcomes following CEA. A recent systematic review of existing models demonstrated significant methodologic limitations, incomplete reporting, and inadequate performance. Furthermore, traditional tools use modeling techniques that require manual input of clinical variables, and this deters routine use in busy medical settings. Therefore, there's an important need to develop better and more practical risk prediction tools for patients undergoing CEA. Machine learning, or ML, is a rapidly advancing field that allows computers to learn from large amounts of data and make accurate predictions. Supervised learning is a subset of ML that leverages advanced analytics to model complex relationships between inputs, such as a patient's characteristics, and outputs, such as their clinical outcomes. This technology has been driven by the explosion of electronic information combined with increasing computational power. Our goal was to develop an ML algorithm that accurately predicts 1 year stroke or death following CEA at the pre, intra, and postoperative stages. We use the Vascular Quality Initiative database, which is a clinical registry that captures vascular surgery patient data from over 1,000 hospitals globally. Trained database managers prospectively record demographic, clinical, and outcomes data on consecutive patients from their initial hospitalization up to 9 to 21 months of follow-up. Annual audits with comparison to hospital claims are performed to ensure the accuracy of the submitted information. In the study, we included all patients who underwent CEA for carotid artery stenosis between 2003 and 2022. The predictor variables used to train the ML models were divided into the pre, intra, and postoperative stages. Preoperative features included demographics, comorbidities, functional status, investigations, medications, anatomy, and clinical presentation. Intraoperative features included type of anesthesia, surgical technique, intraoperative hemodynamics, procedure time, and the need for surgical reexploration. Postoperative features included in-hospital complications and length of stay. The primary outcome was stroke or death at 1 year following CEA. We define stroke as neurologic deficits persisting for over 24 hours in the ipsilateral or contralateral cerebrovascular territory. And we define death as all-cause mortality. The secondary outcomes were individual components of the primary outcome. We trained 6 ML models: XGBoost, Random Forest, Naive Bayes Classifier, Support Vector Machine, Artificial Neural Network, and Logistic Regression. We chose these models because they demonstrate the best performance for predicting surgical outcomes in the literature. We split our data into 70% training and 30% test sets, and we performed 10-fold cross-validation and grid search to find the optimal model hyperparameters. We then evaluated the models on unseen test set data and ranked them based on performance metrics. We first compared the models at the preoperative stage because predictions at this time point are the most important in guiding a patient's care, such as determining whether to proceed with surgery. Once we identified the best performing preoperative model, we further trained it using intra and postoperative data. And the reason we built the models in this fashion is to allow clinicians to understand a patient's risk throughout their surgical course. The primary model evaluation metric was area under the receiver operating characteristic curve, or AUROC. The secondary performance metrics were accuracy, sensitivity, specificity, positive predictive value, and negative predictive value. We further assessed model robustness using calibration plots and Breer scores. And we determined feature importance by ranking the top 10 predictors based on variable importance scores. And here are results. We included 166,000 patients, and 7,700, or 4.7%, had the primary outcome of stroke or death at 1 year. Of the patients who had an event, 1.4% developed a stroke, while 3.3% died. The median time to event was 90 days, and the mean follow-up time was 14 months. This table shows model performance on test set data for predicting 1 year stroke or death following CEA at the preoperative stage. We trained 6 ML models, and the best performing one was XGBoost, achieving AEROC of 0.9, accuracy of 0.82, sensitivity of 0.82, specificity of 0.83, PPV of 0.83, and NPV of 0.81. This performed significantly better than logistic regression, which achieved an AEROC of 0.65. These are the ROC curves for predicting 1 year stroke or death following CEA using the XGBoost model at the pre, intra, and postoperative stages. Performance was excellent throughout, with AEROCs at or above 0.9. These are the calibration plots for the XGBoost model at the pre, intra, and postoperative stages. On the x-axis are the predicted event probabilities, and on the y-axis are the observed event probabilities. The red lines represent the performance of the ideal model, while the blue lines represent the performance of our model. You can see generally there's good alignment between the red lines and the blue lines, suggesting good calibration. This is further supported by the Brewer scores shown here, which demonstrate excellent agreement between what's predicted and observed in terms of event probabilities. These are the top 10 predictors of one year stroke or death in our model, the most important of which was in-hospital myocardial infarction, followed by preoperative dialysis, the need for surgical reexploration, and prior major amputation, among others. When we looked at these top 10 predictors, they made sense to us clinically, meaning that our model was explainable. This is a clinical workflow for how we could use this ML algorithm in the clinical setting. So let's say a patient presents to a clinician with carotid artery stenosis, and they're being considered for CEA. You can apply the ML model at the preoperative stage to get a prediction of the patient's risk of 1 year stroke or death if they were to undergo CEA. Now, let's say the model predicts them to be at high risk of a poor outcome, then you can take a step back and evaluate the patient further. If they have significant non-modifiable risk factors, so older age or poor functional status, then you can consider a less invasive procedure, such as carotid stenting or medical management alone. Now, if they have modifiable risk factors, so uncontrolled hypertension or diabetes, then you could consider referring them to a cardiologist, endocrinologist, or other medical specialist for further evaluation and optimization. Now, let's say the patient proceeds with CEA. You can also apply this model at the intraoperative stage. Let's say the patient has an intra-op complication and the model predicts them to be at high risk of a poor outcome. Then you could consider post-op monitoring in the ICU and maintain a high index of suspicion for complications, whereas if they're low risk, you can provide routine post-op care. You can also apply this model at the post-op stage before the patient's discharged. Let's say the patient has an in-hospital complication and the model predicts them to be at high risk of a poor long-term outcome. Then you could involve allied health to facilitate a safe discharge and schedule early follow-up in your clinic. Whereas if they're low risk, you could provide routine pre-discharge care and follow-up. Overall, accurate predictions from this ML algorithm can inform risk mitigation strategies throughout a patient's surgical course to prevent adverse events following CEA. In conclusion, we used a large granular data set of 166,000 patients to develop robust ML models that can accurately predict 1 year stroke or death following CEA. The performance was superior to logistic regression and existing tools in the literature. Our models can be applied at the pre, intra, and postoperative stages to guide clinical decision-making and mitigate the risk of adverse outcomes. With the advantages of continuous learning and automation, the ML algorithms developed through this study have potential for important utility in the care of patients with carotid artery stenosis. We've made our tool publicly available, and you can access the full programming code here. And this work was also recently published in the Journal of Vascular Surgery, and you can access the full text here. I'd like to thank CIHR, the Ontario Ministry of Health, the SSTP program, and the PSI Foundation for funding this work. Thank you very much for your time.
Hi, thanks, Ben. Thank you for presenting your work. I've had the opportunity now to hear it multiple times at different venues, which is always interesting because you present different increments of it every time. So you had the opportunity to present this work last year, actually, at Gallie Day in a poster, which I was judging. But did you implement any of those suggestions at that time? I think one of them was a question about comparison to clinical expertise, asking vascular surgeons to test the same test against your model, and is the machine learning better than an expert in the field? And are we going to just be demoted to technicians with your machine learning application?
Yeah, thanks, Dr. Greco. So absolutely. So we got RUB approval for that project to compare this algorithm to clinicians. I think that's obviously an important comparison to make if we want to move this model into the clinical setting. And we're also working to try to prospectively validate this algorithm in a clinical setting to see how well it predicts in patients in real time. And really, we want to see whether this model can improve patient outcomes. So these are the projects that we're working on.
Great. My next question is, do you think it's worthwhile to have, you worked with the BQI database, do you think it's worthwhile for them to use this machine learning in their analytics to then assess the quality of each hospital that's contributing to the database and seeing where each hospital can maybe improve on their risk prediction as well?
Yeah, absolutely. So we're working very closely with the Society for Vascular Surgery, which manages the BQI database, and we're looking to, as you said, to compare the risk predictions between different hospitals to see the expected versus the observed event rates. And I think that'll be important in terms of quality improvement as well.
Great, thank you.
Just going to keep us moving, sorry. I'm going to invite Laura up to the stage. Laura is from the Callia lab. She's going to be talking to us today about depressive-like phenotype induced by AAV-mediated overexpression of human A-synuclein in midbrain dopaminergic neurons. Thank you.
Thank you very much. Thank you for giving me a chance to present today and staying all day with us. So my name is Laura. I'm second-year PhD student supervised by Dr. Sunil Gallie and Dr. Tawfiq Valiante, and today I'll talk about behavior and electrophysiology pathology seen in Parkinson's disease preclinical rat model. So Parkinson's disease is the second most common neurodegenerative disorder, which affects approximately 1% of adults over age of 60. The diagnosis of Parkinson's disease follows the development of one or more core motor symptoms, such as bradykinesia, rigidity, or tremor. However, there are a lot of non-motor symptoms, which often, such as loss of olfaction, anxiety, depression, cognition, and those non-motor symptoms often precede before motor symptoms manifestation in Parkinson's disease. The pathological hallmark of Parkinson's disease is the loss of dopaminergic neurons in the substantia nigra and the presence of Lewy bodies, which contain protein alpha-synuclein. Mutant alpha-synuclein is often present in genetic Parkinson's disease, and in the genetic form of Parkinson's disease, and it seems like the accumulation of alpha-synuclein leads to the loss of dopaminergic neurons. So Parkinson's disease, so AAV-A53T animal model of Parkinson's disease holds a great promise as a tool to investigate Parkinson's disease-related questions because it shows the progressive loss of dopaminergic neurons in the substantia nigra and the accumulation of alpha-synuclein. So if you look now at immunofluorescence images on the slide over here, we can see that 6 weeks post AAV-A53T injection, we see a significant TH losses, which is a marker for dopaminergic neurons, and significant alpha-synuclein overexpression, which was not present in empty vector healthy controls. However, little is known about the behavior and electrophysiology pathologies in this model. So I try to investigate this model further to understand whether we can use it in preclinical phase trials. So this is the study design for the behavior battery of my study. So 40 Sprague dolly female rats were bilaterally injected with AAV, 20 animals in each group, and then behavior experiments were performed on week 3 and week 6 when mild and severe dopaminergic neuron loss is seen in the model. So below you can see behavior tests that were performed. So for depression, we use sucrose preference test. Anxiety was investigated with novelty suppressed feeding and open field test. Loss of olfaction was investigated with habituation dishabituation test. And motor impairment was assessed by open field and grid walking tests. And after all behavior tests were completed on week 6, animals were sacrificed and brains were processed to confirm neurodegeneration and alpha-synuclein overexpression, with images of which you saw in the previous slide. So what we found in this model is progressive motor impairment manifestation in open field and grid walking test. So if you look at this figure over here, we can see that on week 6, alpha-synuclein overexpressing animals traveled significantly shorter distance within 10 minutes compared to healthy empty vector controls, and this originated from significantly lower mean speed at this time point. We also saw impaired motor in grid walking test, where alpha-synuclein overexpressing animals missed significantly more bars, and this was reversed with L-dopa administration, which is one of the most common drugs used for Parkinson's disease motor symptoms amelioration. Besides, we also saw depressive-like behavior emerging on week 6, which was manifested as reduced responsiveness to palatable stimulation. So if you look at this graph over here, we can notice that alpha-synuclein overexpressing animals showed significantly lower preference to sucrose on week 6 compared to healthy controls, which could be interpreted as depressive-like behavior. We did some tests for anxiety and olfaction, and we saw no impairment, so I'm not going to go into detail on these results. Now that we know behavior pathologies, it's important to delve deeper into underlying brain activity which drives those pathologies. So for this reason, we took in vivo electrophysiological recordings under isoflurane anesthesia on week 3 and week 6 from subthalamic nucleus, motor cortex, and entopendicular nucleus, which is a homologous of human GPI. These targets were chosen because they are part of basal ganglia circuit, which is involved in motor control, and GPI and STN are one of the main targets for deep brain stimulation, which is a neurosurgical procedure for a subset of Parkinson's disease patients. So just to put my findings into the perspective, in Parkinson's disease patient, one of the hallmarks that people see during deep brain stimulation surgeries is beta oscillations. Beta oscillations is a rhythmic synchronization of neurons in 1335 hertz range. And they are believed to, and they correlate with the motor symptom severity. So what we can notice here that beta oscillations emerge in multiple nuclei as increased power, which can be seen as band over here in representative spectrograms, and we don't see such band in healthy controls. And if you look at statistics, we can notice that beta power emerges in a progressive manner and become very prominent on week 6, where we see significant neurodegeneration and alpha-synuclein overexpression. Then we looked at single neuron recordings in subthalamic nucleus. Again, in Parkinsonian STN in humans, we see increased firing rate of single neurons, and we see bursting activity. In this model, we saw no difference in firing rate between two groups at any time point. However, we saw a progressively emerging bursting activity in STN. So if we now compare representative recordings on week 6, we can see that alpha-synuclein overexpressing animals exhibited brief high-frequency action potential trains, which are known as bursting activity. So now we know that this model exhibits progressive motor impairment, depressive-like behavior, beta oscillations, bursting activity in STN. We are planning to understand the relationship and correlation between those pathologies. And if we fully understand how underlying brain activity and its pathologies drive those Parkinson's disease symptoms, then we can potentially try to reverse them using deep brain stimulation or other treatment modalities. So before I open floor to questions, I'd like to thank my teammates for collaboration and contributing to my research. Thank you.
Great job.
Hong San from a professor in anatomy. So from your abstract, you mentioned the only use of female rats. I don't recall you mentioned here. So what's the rationale using that instead of use both, or you can compare both male and female?
Ideally, we would like to use both female and male rats, but for the behavior behavior test that we use, we try to do them in the same animal over 6 weeks, and male grow quite faster than female. So doing some experiments on week 6 is quite difficult in terms of the size of the animal. That's why we chosen to do it with female.
Okay. But it's kind of known that female hormone is like neuroprotective, right? That's what we wonder. And also probably Parkinson model, probably more pronounced in the male models. That's what probably in the future should compare both animals there. And also, so the AAV expression, you show the picture there is it should be packaged with GFP, right?
Yeah, that's right.
It's not really, and also the alpha synchronous is not really, are they expressed in the GFP positive neuron, or in the picture it's very hard to see the immuno staining picture there.
So in that picture, we just used an antibody which is specific to alpha-synuclein, and that's how we picked it up.
Yeah, I mean, it's if you use the antibody and label that, right?
Yeah.
And then suppose the AAV can overexpress that, that's your model, right?
Yeah.
And then when you see it, suppose you should try to see is those neurons overexpress those, the alpha synchronous, right?
Mm-hmm.
And then you can get the evidence that you actually, the AAV actually overexpress that particular gene, and then you probably going for the other one. But anyway, the other one is on your abstract there, the behavior test seems like more linked to the reward instead of the motor side, right? But your virus inject into the substantial nigra, that's supposed more affected to the motor function part. Only the other side is the ventral terminal, the VTA area that probably more related to the reward for the Parkinson, what they call Parkinsonergic neurons. So what's common on that?
Yes, so there are some papers which show that when we see significant loss of dopaminergic neurons, which is the case on week 6, serotoninergic system is also affected. So our hypothesis is that alpha-synuclein at that time point spread throughout, and it's not sustained just in SN. And also the dopaminergic neuron loss and its projections were severely impaired, which led to serotonergic system impairment as well. And that's potentially why we saw depressive-like behavior at later time point, but not at the mild neurodegeneration on week 3.
Okay, yeah, thank you.
Okay, I'm going to welcome up Jonathan Lex, please, to talk to us today about improving elective arthroplasty procedure scheduling with machine learning prediction and optimization. Thank you. Welcome.
All right, thank you very much. My name is Jonathan Lex. I'm an orthopedic surgery resident and just recently finished the surgeon scientist training program here. We're talking to you about total hip and knee arthroplasty and trying to improve the efficiency we can deliver of our care to all of our patients. It's a very common procedure, very reproducible, but it is very resource intensive, taking a significant amount of hospital resources and operating room time. As mentioned, it's very common and it's only going to increase as our population ages, and so it's going to become a growing burden on our healthcare system in terms of the amount of resources it requires. These are very relatively reproducible procedures, and so there are efforts to try and improve the efficiency of them, including bundled care models. But there is a large target on orthopedics as well as, and specifically total hip and knee arthroplasty, to try and deliver efficient care. It is an elective procedure, so you have a large wait list of patients. It's not something that happens emergently. Wait lists can be very long. In Canada, only 53% of patients are getting their total hip or knee arthroplasty within the recommended window of 6 months. And the main bottleneck is our infrastructure, being the actual operating room time, with surgeons burdened with large wait lists that they're trying to manage. Currently, this is done on a first-come, first-served basis, essentially, with how patients are scheduled. It is all very manual, and surgeries, the most sophisticated way we have to book them, are based on a rolling average time. Other times are based on a clinician estimate or just the average time for that procedure. A surgeon's assistant schedules the patients, as mentioned, on a first-come, first-served basis, and this is dealt with by the OR administration, all very manually, leading to errors, decreases in efficiency, and expenses for our system and hospitals. So essentially, what is the goal? Well, currently you have patients or pieces coming in at a very fast pace, and you're trying to fit this into specific blocks of time that you have. But imagine the goal: you can predict what's coming, select the specific case that fits your existing schedule, and make it fit closer to ideal as possible. Strategies to possibly achieve this: well, first, what do you need? You need to know how long the surgery is going to take on a more accurate basis, leveraging machine learning for that, and then optimizing our schedules using advances in computation and mathematical optimization, where we're harboring those two different strategies which have historically been used independently and linking them together to develop a new process for elective scheduling. This is the overall flow that we developed. First, taking your patients, identifying the procedures that you're going to build specific models for, and getting highly granular data that's recorded is essential. And then you need to develop your predicted times and your more specific duration of surgery estimates using machine learning, and then develop your optimized schedules. So how we did this is, largely for most of the work is done at Sunnybrook using institutional data, combining the granular operational data as well as patient-specific hip and knee database data. We did use the NISQIP, which is a North American data, for some of our more theoretical work. So in first step, the prediction, using patient factors, their demographics, height, weight, patient comorbidities, to develop the model. We compared initially 10 different machine learning models and looked at their output, which was our predicted duration of surgery. We used metrics, traditional machine learning metrics, to compare models, as well as things that are more interpretable to us as clinicians that we developed: the buffer and classification accuracy. Buffer being, what is the actual time? Give a buffer of, we span this, but imagine 15 minutes plus or minus around the surgery, and then it's an overall percentage of if you're within that buffer of the actual time that the surgery took, and then classification accuracy if you're on the right side of a cutoff time. We compared our models. We found that neural network models, when comparing the traditional mean squared error as well as buffer accuracy, were the most accurate. And so we took that neural network model that we developed on our more larger database and applied it at Sunnybrook. The neural network model we chose was a multi-layer perceptron, a fully connected neural network, focusing again on the outcome of duration of surgery. We looked at other outcomes, but for this we'll focus on our duration of surgery. Over the 10-year period at Sunnybrook, we had 15,000 cases, and we split our data by year. So when we were predicting on our test set, this was future unseen cases that would be coming in the future. And so it's a bit of a different way to split our data. The number of features vary between 40 and 50, and these were 4 different models specific to the actual procedure. What we found at Sunnybrook was, the historic, what they're using is this rolling average that is specific to the surgeon and the surgery performed. It is relatively accurate, around 53%, but in terms of our 15-minute buffer accuracy. But using our neural network, we could increase that to nearly 60%. So it's a 7% improvement, but these are very common procedures. And how did it get there? Well, one of the main concerns with using a neural network that people have in clinical studies is it's a black box. One of the more recent advances in trying to understand what the neural network is doing is using SHAP values, which leverages game theory to understand. And it unsurprisingly shown that the rolling average historically that was used was an important feature. The operative side, as well as our implant details that were used, those specifics of the implants were the most important in predicting our times. Okay, so now we have a decent estimate of how long the surgery is going to take, but we need to develop a schedule. And so we compared 3 different strategies overall, again, more theoretical work, looking at 3 different formulations. One being where we let all of our surgeons operate at any operating room time and tried to see what the ideal schedule would be. Split, where we had 2 surgeons sharing an operating room, and then MSSP, or the multiple subset sum problem, where you're essentially taking one surgeon's wait list and trying to maximize their OR time. Surprisingly, we found where we gave it the most flexibility, it actually performed worse in terms of the underutilization due to errors in our prediction, and similar between having 1 or 2 surgeons in a room. And so for future implementation purposes, we stuck with 1 surgeon per room moving forward. This is the math for that problem. Essentially, we're trying to maximize the operating room utilization, and the model has a penalty for going overtime. And priority cases, which we counted as our revision cases, had to be done within the planning horizon, which was 1 week. So we did simulations of these schedules over our test set, which is around 1.5 years, and compared the 3 schedules now using our predicted machine learning time, using the existing rolling average time, and just a mean time. We ran the simulations using our optimized formulation and compared our schedules in terms of the underutilization, the amount of overtime, and the number of cases completed. And so we found around 15 minutes per operating room per day was saved, and these cases were fit in a bit more jam-packed, so there was a slightly increased amount of overtime by about 4 minutes. But what this equated to by fitting our cases in better was actually an additional 83 cases per year completed. But most importantly, our time to complete all of the cases within our test set was in 66 fewer OR days, which was about 12.5% improvement in the utilization when combining that improvement that we have in our prediction plus the optimization. But just the efficiency of the operating room time was not the only thing we wanted to consider. You are fundamentally changing how you're scheduling and choosing cases, and so we need to consider multiple objectives now. So the overall utilization, how long patients are on the wait list to ensure patients are not waiting for years and kept getting skipped over, as well as we decided to include their preoperative function on how much patients are struggling preoperatively with their hip and knee arthritis. We ensured also that these scheduling was fair, ensuring no difference in gender, age, or sex, gender, age, and BMI across patients that were scheduled, and making sure it wasn't making schedules more efficient by choosing the shorter cases. And so we actually found it did slightly more longer and shorter cases that it was selecting. And then by increasing how much we were accounting for our preoperative function, which is our WOMAC score, as well as the wait time, it didn't actually have an effect on the OR utilization, and so we can improve and ensure the fairness for these patients without affecting our overall efficiency that we found before. And this shows that the patients that we're choosing were the ones that were suffering more in terms of their preoperative function, the more we accounted for that, again with a minimal impact on the actual efficiency. And so overall, we developed these machine learning models for surgeries that are done over 130,000 times a year in Canada, which can improve our efficiency by around 12.5%, which magnified across that volume could be quite a significant impact for our healthcare system. It was non-discriminatory against our patient features, and it does consider wait time and how much patients are suffering preoperatively. Next steps, we plan to implement this and actually use it and compare it against schedules that are currently generated. I'd like to thank specifically my supervisors as well as the rest of the team who have helped and supported me through the work on this. Thank you very much.
Very nice work, Jonathan, and congratulations on completing your master's.
Thank you.
I guess my question is, like, how do you think, can this be extrapolated to procedures? I guess that's a pretty obvious question, but like you really chose within orthopedics, the one I know that you're personally interested in, but also that's the most reproducible surgery that we do. So do you think this can be applied to specialties with a little bit more variability, like oncology, for example? And do you think we have, like, how many numbers of these cases, like you were able to draw from, you know, over 10,000 cases, like how many, what do you think is the critical number of cases that you need to have data for to apply to, again, something that has more variability into it?
Yeah, so a good question. I mean, in some way, arthroplasty is an easier question because you have those volumes, and they are largely impacted by patient factors that are identifiable in large data sets. But for something with such variability, such as oncology or trauma, where it's perhaps the things that aren't going to be captured in a database, such as, you know, patient characteristics or comorbidities that impact your duration of surgery, but perhaps things like the location of the tumor, how close it is to blood vessels, and how long that's going to take you. I think this approach can work overall for any procedure, but for the machine learning part, to get a more accurate prediction for your duration of surgery, you'll need different features, and that might be imaging, and so, you know, looking at where the tumor specifically is located, and maybe proximity to vessels could be a feature, the size of the tumor. And so I think you can extrapolate it, but the machine learning aspect of it would have to be variable to get you an accurate time.
I'm also curious, like, when you do this prospectively, are you going to stay now within Sunnybrook, or are you going to see how this also, like, do you think this is going to be applicable to other sites?
I think it should be, as long as we have the data and the site does collect the data. We were fortunate at Sunnybrook that they've been collecting this data for 10 years, and we were able to link it with operational data that's recorded in the operating room time to create this unique granular data set. I think if the EMRs at specific hospitals do collect that data, and you can develop the models, it should be applicable across different hospitals. We're going to pilot it at the Holland Center at Sunnybrook, and then hopefully it can improve efficiency elsewhere. There are other provinces. Ontario has long wait lists, but there's other areas, as we've seen, with longer wait lists and more difficult access to care. And I believe if we can generalize it to all of Canada, that would be the best for access to care for our patients.
Thank you.
Thanks.
I'd like to call on Professor Swallow to make a few remarks.
So I basically want to thank all of you who are still here because it's very important, I think, for our trainees and students who've gone to such an effort to prepare their talks so professionally and who've generated this kind of high-level science to have a receptive audience before them, so I really appreciate your being here, and I would like you to applaud yourselves. It's been a fantastic day and really dense experience. I so much enjoyed Professor Mera's talk and will thank him again this evening appropriately. The main thing I want to convey to you at this point is that the dinner is sold out. This is a rare event. But we don't have any seating available at dinner anymore, Dr. Redick, I'm sorry. However, you can come to the cocktail hour, which is at 7 to 8 at the Park Hyatt. So that's on Avenue just north of Bloor. You'd be very welcome to come. This is our 50th anniversary gala banquet. We have a few extra features beyond the usual. We have a Global Surgery Hall of Fame for you to enjoy, and we also had a professional photo booth with digital photos that will be sent to you later with you and whatever colleague group you want to get together with in whatever pose. You'd be very welcome. So hopefully we'll see all of you at the cocktail reception, 7 o'clock, Park Hyatt, and at dinner tonight. And thank you again for being here.
Well, we've had a wonderful day, and it's my pleasure to now kind of bring this to a close. So this has been 50th Gallie Day celebration, and I think that Dr. Gallie would have been very pleased with how the evolution has gone. I want to thank all of the trainees for wonderful oral presentations. The e-posters were also wonderful, and congratulations to all of the supervisors. A big thanks to Professor Mera for a wonderful Gordon Murray lectureship, and we had a wonderful symposium, so thank you to Anna Adair for helping to organize this and for all of the speakers. And big thanks to the support staff from the Department of Surgery, particularly Renata Musa and Sylvia Perry. And on that note, I think we'll close things out and hope to see many of you at 7 o'clock. Should be fun.